So we're actually on YouTube and JNO right now, live for the YouTube. It's streaming.
Yeah, I think it'll work on all different streaming platforms besides Instagram. Unfortunately. But I got it.
We're live on Instagram.
Oh, cool.
Yep, I'm staring at myself right now. It's great.
Really? I see you too. Oh my God, amazing.
I'm staring at myself right now. It's a slight delay, but it's good.
Yeah, it's good. Really? I see you too. Okay, I need to mute myself. What do you have to say to your fans?
Well, it's the Lenox Hill fans, not my fans. But I think we're going to get this to work on YouTube, Instagram. This would be nice. We'll get this on the JNO Instagram page too soon.
What's your favorite color?
My favorite color, probably green. What about you, Flora?
Mine's purple. What's your favorite color?
Purple. Is your audio on your phone? We're going to get started soon, everyone, with Tumor Talk. We're just waiting for Dr. D'Amico and the rest of the gang to start up.
I'm in front of Lenox Hill Hospital.
It's John Bookvar's favorite place to take pictures.
John Bookvar got verified on Instagram today.
I saw he got a blue check. Everyone should give him an extra follow or tell your friends to follow him. He's a real celebrity now.
Everybody who's on our Instagram Live, don't go anywhere. Tumor Talk is going to start.
Starting in 5 minutes, everyone. This is just a pre-show checkpoint.
Hey, everyone.
Hey, check your Instagram. We're live.
Oh, is it working?
Yeah.
Oh, you're a machine, buddy. That's fantastic. So what are we're doing on JNO We're doing on Lenox
YouTube.
Hill. We're
YouTube.
doing on and both YouTubes.
Both YouTube. Well, we're only on one Instagram account.
Okay.
Lenox, so I need to log in for the other. I can get it done.
Oh, from Galtum. Okay, great. So we'll email you that. That's fantastic. You think both will work?
Yeah, I think so. Well, after a few hiccups, we'll get it to work.
That's incredible, man. You're a wizard.
Yeah, Fresh is a wizard. But maybe you can make it gallery view.
Oh yeah.
Yeah, on the Lenox Hill account, we'll have to do a gallery view.
You got to adhere to Flora's strict stylistic concerns, okay?
How do I do it? You tell me what to do. I'll do it right now.
So,
You got to go to the top right, right?
Okay, I see it right here. Good, got it. Boom.
That's excellent. Let me drop a quick Instagram. We're going live. Fantastic. Edjah and Brett are online.
Hey guys.
Yep.
How you doing?
Good. About yourself?
Great. So just so you know, we've had a few advancements in Tumor Talk, which is awesome. We actually have now the ability, we're streaming live on the Lenox Hill Instagram. We're streaming live to both the JNO and the Lenox Hill YouTube. And by next week, hopefully we'll be live on both the JNO and the Instagram for Lenox Hill. So
Awesome.
we're getting fancy.
Josh, I have a question. Is it streaming from your computer, like your desktop?
It's all web-based streaming. So I basically have Restream as a software just redistributing the Zoom feed to 3 different channels, which is
Or is
Lenox
it like
Hill.
mirroring your computer screen? Because on the live, it's like cut out a bit. So maybe you can shrink the window, you know?
Not a bad idea. Let me try that. It might be doing that.
Hey, Edjah, how do you pronounce your last name? Just so I don't sound terrible.
You're good. So the easiest is just Nduom.
Nduom, okay.
Yep.
You know, I share an office right now out in Brooklyn with a Johnny Nugent who knows you, I guess, from Emory days.
Yes. He
great.
was a ENT guy. Yeah, it was a year behind me training-wise. He spent a month as an intern on the Neurosurgery service. A good guy.
Yeah, great human. I love sharing an office with him. So he's
awesome.
he's doing plastics out there in Brooklyn.
Yeah.
Specializes in actually gender reassignment surgery now too. So yeah, from ENT all the way down, I guess.
that's quite a reach.
Yeah.
You know, just down. You know, big operative field. But that's awesome.
Yeah, he's doing well. He said hi. So
Good deal.
all right, and Jason's online. Hey, Jason, how you doing?
Good. How are you?
Great. Doing a little work from home today. How you doing, Brett?
Doing good. Thanks.
Welcome.
Thanks for joining.
So why don't we kick off? It's 4 o'clock. We try to limit these to about a half hour. So welcome, everyone. Welcome to Tumor Talk, the weekly collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we like to sit down with the authors of recently published articles in the Journal of Neuro-Oncology, discuss the reasons, the results, and the rationale, and the relevance, really, of the studies of brain and spinal cord tumors. So today, as always, I have Jason Sheehan from the Journal of Neuro-Oncology. We're visited again by Nitesh Patel. He's a chief resident at Rutgers. And then our special guests today are Edjah Nduom and Brett Theeler, who are going to present today on a recent survey study they did looking at attitudes on stereotactic biopsy for adult diffuse midline glioma. So super excited to have you guys. Thank you so much for the time. Just one last quick thing, and Jason, for you too. We are streaming now on Lenox Hill YouTube, on the Journal of Neuro-Oncology YouTube, as well as the Lenox Hill Instagram. By next week, we should be on all Instagrams. So expanding our reach weekly, which is great. But welcome, guys. Thanks so much for being here. We'll let you guys kind of do your own thing. It's pretty free form and informal. So thanks a lot.
Good deal. All right, Brett, you want to go ahead and get started?
Yeah, sure. Sure thing. Here, I'm going to share my screen here. All right. All right, hopefully you're seeing a PowerPoint slide now. Put it in
Yep, coming through.
mode. Okay, good. All right. So hey, I have to do this quick disclaimer. I work for the government. None of what I'm going to say is the okay. And so just, this is an NCI Connect effort, which is the rare cancer program at the NCI Neuro-Oncology branch, ran by Dr. Mark Gilbert and Dr. Terry Armstrong. And one of the best parts of my job at Walter Reed is I get to be a contributor to this network, which is a clinical trial network, a patient engagement network, and a translational research network. So happy to represent the NCI Connect today. And we do have a clinical trial that includes diffuse midline gliomas as kind of the highlighted tumor with a drug called ONC206. And if we have time, maybe we can talk about that as we go. And so Dr. Nduom asked if I just gave a quick summary of diffuse midline gliomas. And so I'm going to fly through these slides. Okay. So we've known for some time that there are more brainstem tumors in pediatrics than there are in the adult population, which by itself is an interesting observation. Also, as you can see in the upper right, that's pretty much what every DIPG survival curve looks like, with almost zero, with almost 0% 2-year survivors. And we've known for some time that adult brainstem tumors, infiltrating tumors, have time, or at least a subset of patients survive longer, even though the tumors often will look very the same, will look very much the same on both MRI and under the microscope. And so, thanks to the efforts of pediatric neurosurgeons and pediatric neuro-oncologists who developed studies that really had their primary focus to obtain tissue from DIPG specimens, a seminal discovery of histone mutations was found, which are mainly found in midline pediatric tumors, especially the diffuse intrinsic pontine gliomas, as shown in this figure in this table here, with almost 80% of DIPGs in pediatrics having a histone mutation, and a smaller proportion of hemispheric pediatric tumors, which is actually usually a different mutation than that just seen in the DIPGs. Okay, and then it's a little bit different story in adults, and so a smaller subset of infiltrating astrocytic tumors that are IDH wild type and are in the midline have the same H3 mutation that's seen in pediatrics, and you can see here that they have a similarly poor outcome to the typical glioblastomas that are IDH wild type. I'm not going to pretend to be an expert on histone biology. I think, like IDH mutations, it's a biology we didn't expect to have to know. As cancer doctors. And so here's a reference where you can look you can look and learn more about it. And so this is sort of just a pictorial representation of some of the diffuse midline gliomas that we've taken care of at the neuro-oncology branch. And you can see that they often, just kind of one thing that kind of jumps out is they don't often have the typical DIPG appearance that we see in pediatrics. They occur most often in the thalamus, actually, in adults, but also see brainstem, spinal cord, and even hemispheric tumors that have histone mutations. And just one observation, that has been made a couple of times, including at the NIH, is that some of these tumors have almost a circumscribed appearance, not a completely circumscribed appearance, but often don't have that infiltrative DIPG appearance that you frequently in pediatric patients. And again, just a quick, kind of a quick overview of the pediatric experience. So again, most tumors are in the pons, other midline locations less commonly. There's a couple of stains that, we're now getting on all of our, midline cases that stain both for the trimethylation on the histone tail, and then the H3K27M mutation, which stains the tumor cells that have the mutation, much like with IDH. Okay, and in pediatrics, there's actually, again, a very poor outcome for these tumors with the standard of care usually being radiation therapy alone. There is a subset, however, you see in that dark green curve that have a different histone mutation, but better than the most common mutation. And then this is just sort of a representation across the age range of where we see most diffuse midline gliomas, with the H3K27M mutation. And you'll see that sort of the pontine tumors cluster in the pediatric and kind of adolescent young adult population, whereas as you get older, you're more likely to have a tumor in the thalamus and outside of the brainstem and other midline locations. And so again, the outcome for these tumors in pediatrics is poor. If you have a histone or mutation, the outcome is similarly poor in adult patients. Maybe, it has been noted that adult diffuse midline gliomas do appear to perhaps have a little bit better prognosis than the pediatric tumors. That may be in part due to the fact that more are located in the thalamus and not the pons, and perhaps there's other biological differences that we have not yet discovered. This is a helpful reference that really looked at a large number of infiltrative astrocytic tumors in adults that were in the midline. And what you'll notice is only about a third of adult midline gliomas have the H3K27M mutations. They have other mutations as well, including IDH. And these tumors have different, different biologies, different outcomes. You certainly want to identify it in IDH mutant tumor. It's going to have a much better prognosis than an H3 mutant tumor. So again, a difference in the adult versus the pediatric populations there. I think that is almost my last slide. So now to kind of take us to where we are now. So we have the NCI Connect, again, a rare brain and spine. This is a picture from the website. Diffuse midline gliomas is one of the tumor types that we focus on. If you Google NCI Connect, it's very easy to find. That's a patient page that you can give to your patients. We held a workshop in September 2018, inviting neurosurgeons, neuro-oncologists, basic and translational researchers, and radiation oncologists to discuss these tumors really from the adult perspective, and to try to kind of understand, learn more, and create goals, action items to further the research. Myself and Dr. Dalal, a histone researcher at the NCI-NH, chaired this very exciting meeting. And we have a publication which is free online, which you can access as here on Neuro-Oncology Advances if you want to read more. And so we came out of this meeting with action items. And so here's a picture of all the folks who attended the meeting. And it's easy to find Dr. Nduom and I because we have the baldest heads and the biggest smiles. And you can see the action items there. And it's really number one that we're going to focus on today. And I mean, fortunately,
Okay, couldn't hear Brett at the end there, but I think it's time for me to jump on. So, okay.
We lost him for a minute, but I think he was talking about action item number one, right?
Yes, action item number one.
Yeah, do you want to just summarize it one more time? You cut out for a little.
I did. Okay, that was weird. I'm sorry about that. So really, as I was saying, Edjah's paper is really based on action item number one. And thankfully, he took that to heart and took that project on after the meeting.
That's fantastic. I had a feeling.
All right, perfect. Thanks, Brett, for that wonderful introduction and overview of everything that we did there. I'm going to go ahead and share my screen. Everybody seeing my presentation now?
Yep.
Brett's presentation was very heavy on what we call data and science on midline gliomas, and that's really why I wanted Dr. Theeler to come on here. If you've ever spent any time around Brett, it's like basically walking around PubMed, which is super helpful when you're dealing with rare lesions like this. The workshop that we convened, that they convene is NCI Connect, was really quite helpful and eye-opening for myself. I think as neurosurgeons, we don't spend necessarily a lot of time thinking about midline gliomas. I know when I trained, really it's a lesion that you take a look radiographically, and really in pediatric neurosurgery, in a lot of cases, the discussion would be, well, does this patient need a shunt or not? And if they don't, if there was a particular trial that required tissue, maybe you do a biopsy, but that wasn't really something that was done very routinely. And I think that's changed somewhat in the pediatric world, as Dr. Theeler went through, and that's why we know about histone mutations and some of the biology of these tumors, and can differentiate between some of the IDH mutant tumors versus IDH wild type tumors and H3K27 tumors, and try and put them in different boxes and look at the pathology. But in adults, we don't have quite as much information as we do in pediatrics. And again, that's partly because of the approach that we take to them as adult neurosurgeons. So what we really wanted to do after this working group, where really everybody that was sitting there was like, well, we're not going to make any progress if we don't get more tissue on these lesions. And so we started talking about, well, how could we get more tissue on these lesions? Should we be doing training on how to safely do these biopsies? Should we be talking more about the clinical trials that are available? And really the answer we came up with is we're not really sure, because we're not sure what neurosurgeons would want in order to make them more likely to biopsy lesions. And that's where the impetus for this paper came about, really, again, directly out of the NCI Connect workshop, which I'm very thankful for Dr. Theeler for organizing. So what we wanted to do was assess the attitudes of neurosurgical oncologists specifically about their management of these midline gliomas. So we put together a quick essentially it started with a 10 question survey. And actually, thanks to Dr. Sheehan and the survey committee of the tumor section, we were able to get some really great feedback and turned it into a 16 multiple choice question, which did have some open-ended prompts and also some logic, which Alvina Quay in the NCI Connect program kind of helped us with, because I'm a novice with SurveyMonkey. She's actually quite a whiz at it. There's a lot in there that, again, as a neurosurgeon, I wasn't even aware of. But this is some of the information that we got. So we sent it out to the tumor section. We used the tumor section social media sites, the Twitter site in particular, to help get the word out. If you're on Tumor Talk, whether that's on Instagram or YouTube or whatever, you probably are aware of the tumor section social media. But if you're not, at NS Tumor Section, it's a great font of information. And these are the responses that we got. Not surprisingly, going out primarily to the tumor section, we did get most of our respondents being in academic centers, with some in specialized group practice, very few in solo practitioner or private practice. Most are participating in tumor boards at some frequency or another. And if you look at gliomas, though, there is a bit of a spread, which is interesting. Of course, as most of us know, tumor neurosurgeons span from glioma surgeons to anterior skull-based surgeons to open skull-based surgeons. And so there are some that are doing quite a few gliomas and some not doing not as many, which of course was going to be informative for the study. So really we wanted to get an idea of, again, is how many tumors in general patients were seeing, particularly gliomas, and then really hone in on whether they were seeing patients with diffuse midline gliomas, which you can see the numbers are quite small, because really there aren't that many diffuse midline gliomas presenting in the United States every year, let alone those that are getting operated on or referred to neurosurgeons for operations. And then we wanted to ask them where they would or would not biopsy these lesions. And so we tried to split up, kind of diffuse midline locations into the basal ganglia, the thalamus, the brainstem, or the spinal cord. And basically, if you're looking at the none section, that's basically people that would be more than willing to, biopsy a lesion in any of these locations. But you'll see that many of the neurosurgeons would not biopsy lesions in some of those locations, with about half of our respondents saying that they would not biopsy a lesion in the brainstem, which of course, as many of these lesions do present in the brainstem, that becomes an issue. The thalamus, interestingly, again, being a frequent location for these lesions in adults, is someplace that adult neurosurgeons are more comfortable biopsying, which again may be just simply from the fact that many of them do present there. So we then wanted to drill in a little bit into why these neurosurgeons weren't maybe biopsying in certain areas, to maybe start to get at the psychology and say, okay, well, if this is your reason why, is there some way we'll be able to address that in the future and thus make you more likely to consider a biopsy? So like I said, 41% would routinely consider biopsies in all of these locations for various reasons. 51% again won't just generally go into the biopsy and into the brainstem. 70% of neurosurgeons who would not biopsy in some area. So if they picked one of the areas they won't biopsy, 70% of those respondents would say that procedural morbidity was one of their concerns, with 58% indicating that morbidity was their number one reason not to biopsy these lesions. 37% reported that they wouldn't biopsy these lesions, at least in part, because they felt it would not change their management decisions. No matter what the tissue was, they weren't going to do anything different. With 24% of those respondents saying that the not changing management was the number one reason not to biopsy in these locations. Reasons for offering biopsies, on the other hand, generally fell in line with patients saying that their medical oncology or neuro-oncology colleagues would not initiate therapy without having a tissue diagnosis of the lesion. So if they're working with a medical oncologist or a neuro-oncologist or radiation oncologist who isn't going to treat the patient without knowing definitively what it was, then that's a lesion that they would consider biopsy. But there were some patients who did not offer biopsies, and instead they would just refer the patient directly to a neuro-oncologist, radiation oncologist, or both at their institution. With only 5 respondents who do not biopsy saying, okay, well, I'm not going to biopsy them, but I'll refer them to another center for that biopsy or to consider other treatment elsewhere. So most of these patients are getting treated locally, at least with our respondents at the center they would present to. One of the interesting things we wanted to look at was whether time since training affected the likelihood to offer a biopsy. We thought that maybe, with some of the new literature coming out saying that it's safe to do this in pediatric patients, that maybe some of the younger neurosurgeons were a little bit more gung-ho to do this, but it was completely irrelevant to the decision of whether to biopsy or not. It was rather the other factors of what happened at their location that did affect the biopsy. So so we asked the surgeons what they would do with the tissue once they got it. And so for a few of the respondents, not many, but some really said that all that would happen with the slides is just H&E, right? There wasn't going to be any additional molecular testing done with it. And those respondents were less likely to say that clinical trial eligibility was a factor or the most important factor in whether or not to offer a biopsy. So really, they weren't considering clinical trials at all if all they were doing at their center was H&E staining. However, if they had molecular testing or sequencing available at their center, they were more likely to say that, hey, clinical trials that we know about are things that would influence our decision to offer a biopsy or not. And again, for 55% of surgeons who offer biopsies, they do consider clinical trial eligibility and management of these patients. But it's really only a small subset of those who consider it the most important factor in offering a biopsy. We also had these other categories. So we did have qualitative analysis of these, where if you look at the paper, there's kind of a word cloud of the things that popped up more frequently. And we started to put these into different categories so we could classify these other responses as well. And basically, as far as making the decision to do a biopsy, some were just saying it was a little bit nuanced. There was a consensus of a multidisciplinary team, so they don't routinely offer a biopsy in all these patients. But if the whole team thought that this particular patient needed one, say because there was some disagreement on it being a pilocytic astrocytoma versus something else, then that's a patient they would biopsy. They make it on a case-by-case basis. And interestingly, some were saying that, well, hey, if we knew that there were trials at other institutions that required tissue, then maybe I would do a biopsy, but I don't know any. So these are not patients that I would biopsy. The last real factor that I'll go over, and then we can get to the discussion, is really that there was some difference in the patients who operated on fewer gliomas versus more gliomas, which basically, if surgeons operated on fewer gliomas, they were more likely than high volume surgeons to cite surgical morbidity as their most important reason for not offering biopsies in particular anatomic locations. And to the idea of, well, maybe if we were training people more on the fact that these were safe or providing, courses on stereotactic biopsy, the brainstem that they do it more likely, most of these surgeons didn't really feel that they needed additional training on it. They thought that they could do it just as well as anybody else, but still they thought it was just too dangerous to biopsy in these locations. And this is just a look at that kind of last question we were asking, what do we think would really make you more likely to consider biopsies on these patients? And most of the respondents did respond to that. And the biggest thing I think really that came out was, if there were treatment options or clinical trials that required tissue for these patients. So if knowing that they were an H3K27 mutant patient would make a difference for what you did for the patient, that would make a difference. What I thought was interesting, though, there's still a solid 40% who said that, if there were more publications demonstrating safety and utility of the procedure, that they'd be more willing to offer biopsies, when there actually is quite extensive literature, particularly in the pediatric world, that shows that these biopsies are quite safe. And really, if you compare the morbidity and mortality information for just a general stereotactic biopsy in the brain, which most neurosurgeons are very comfortable with and will do quite frequently, there really isn't much of a difference between what you see for supratentorial lesions with what you see for brainstem lesions, with them being quite safe with the higher mortality rates from a couple studies being at about 1%, but most really putting the morbidity range somewhere between 2 and 8%, which again is quite similar to what you might see in your average stereotactic biopsy. So really conclusions is wide variability in practice and beliefs around stereotactic biopsies. I think our survey does present some opportunities for education on these, particularly around the safety that's been reported in doing these stereotactic biopsies, as well as the clinical trials, as Dr. Theeler mentioned, the 206 trial that's going to be starting at the NCI Clinical Center from the NCI Connect group, as well as others that already exist, looking at, say, ONC201, where there are arms of these studies that do require tissue diagnosis of an H3K27 mutant lesion. With that, I just wanted to make sure that I acknowledged, in particular the NCI Connect team and everyone that participated in the diffuse midline glioma workshop, of which Brett mentioned several of those participants. And in particular, highlight, of course, Dr. Gilbert and Terry Armstrong leading the Neuro-Oncology branch. And thank Brett for participating today, inviting me to that workshop and giving such a wonderful introduction on these lesions. With that, I'll end the questions.
Thanks so much, Edjah. That was great.
Yeah, fabulous set of talks, Brett and Edjah. Just great.
It's really fantastic. Yeah, thank you.
So, I had a bunch of questions about this. I mean, it like all good research, it leads to more questions, more so than anything else. But I guess, one interesting thing that stood out to me is that, like you mentioned already, this was actually, primarily academic neurosurgeons, right? This is a survey that went out to major academic centers with multidisciplinary tumor boards. And my question is, what are other institutions doing if morbidity scares, people at top centers that handle decent volume of gliomas or not so much, but, what's happening in the community with these tumors?
That's a excellent question. I think we can guess. We did not, as reported, we really sent this out to the tumor section mailing list, then used our social media to put it out there. And based off of the demographics, you can really see this is primarily ivory tower neurosurgeons who are responding to this survey. I would argue, quite strongly, having trained at MD Anderson and Emory, and then being at the NIH, I've been to a few different places. In all of those places, they're pretty aggressive with these biopsies, most of the surgeons. But even in those centers, there's a couple neurosurgeons who maybe, doesn't really feel that there's a need to do it. I'd argue that outside, you're likely seeing much less propensity to biopsy these lesions. And so even though we didn't have anywhere close to 100% or even most of the neurosurgeons biopsying in all cases, I think we're skewing towards the more aggressive surgeons. In that on the community, the vast majority of these are being referred directly to a radiation oncologist for radiation without consideration of biopsy or clinical trials.
So then my follow-up though is should these tumors be referred? Should this be a guideline suggestion, by the higher ups in neurosurgery, sending patients who have these issues to major centers where even if a biopsy is not performed, at least, you're having experts look at them. These are obviously complicated lesions.
Yeah, this is another area.
Yeah,
this is another area where I'm biased. So a couple things. One, our data shows pretty clearly that the neurosurgeons that have a higher glioma volume. So if you're an intrinsic, tumor person, that's kind of the practice that you have, where there's enough of that in your practice. Those surgeons seem to be a little bit more comfortable with the idea of the morbidity being there, and knowing, how to manage that morbidity and feeling that they can get away with these biopsies pretty safely in most patients. Whereas even a tumor identified neurosurgeon who does less glioma seems to be a little bit less comfortable with that idea. That all speaks to the data that we have across many different publications and many different subspecialties in neurosurgery and other surgical subspecialties where volume makes a difference. And in a lesion as rare as these midline gliomas are to even present to any center, where even in the high volume centers, people are seeing less than 10 a year, I think it absolutely would make sense for, if this is the one you're seeing every 5 years or, once in a couple of years even, it might make sense to refer this lesion, to another center where they might have a clinical trial available, or at least would know of the clinical trial that's available at the other center that's a regional center, even if it's not at that particular institution.
Well, I mean, I think that's an excellent point. I think it's 100% accurate. I think the question then becomes: is some sort of research consortium also necessary? Because there are obviously centers kind of peppered throughout the country and the world, really. And you talk about the rarity of these lesions in the paper, and I don't know if our viewers range. We have students to patients to clinicians. What I'm not sure patients exactly realize is that in order to make progress in treating these things, we need the tissue. We need to study it. We need to figure out what makes the tumors tick, basically. And so with a rare lesion like this, to have less than 10 a year in one center to draw any real conclusions is difficult, right? Yeah. So I don't know if you guys are looking into, or has anyone looked into, creating a tissue bank, a national consortium to acquire this stuff so that we can make advances.
Brett, do you want to speak to the NCI Connect efforts around kind of consolidating rare CNS tumors in trials? And
yeah, no, that's, you're bringing up what is the big issue and the difficult issue. And of course, the NCI Connect is one example of a trial network. And then, of course, the goal is to collect cases with clinically annotated tissue specimens. And I think that is what is absolutely key. And one of the action items, is, for example, is to better coordinate pediatric and adult clinical research efforts. I don't think it makes a lot of sense for tumors that have the same biology to be separated arbitrarily at age 18. And so it gets to, there needs to be clinical studies, even if they're clinical studies where collection of tissue and I'm collecting natural history is the goal, which is really one of the main efforts of the NCI Connect with these rare tumors, is to try to find patients, engage with patients, give them a place in the least to send their natural history information so we can learn more about them. And of course, if you add natural history with some tissue biomarkers, you really have something powerful in some of these NCI Connect tumors where there's only a few hundred per year in the US. And so, hopefully that answers the question.
No, totally, yes, definitely.
That yes, absolutely, we need to be collecting patient information and really collecting patients at referral centers whenever possible, so they can have a full multidisciplinary evaluation. But I think that goes beyond just seeing an experienced neurosurgeon who's done this before. That really, gets to having an experienced institution that can do the full range of testing, and is trying to answer, clinical questions, run clinical trials with that information.
And just piggybacking on that, I'll just say, you said you have patients on that participate in these calls, and the patients are our partners in this work. We don't have any of these advances in any of the tumors of the patients who at the time do not know that there will be any benefit from the tissue that's being taken, and take on the risk themselves, right? I'm the neurosurgeon, I'm not taking on any personal risk, but they are. And by and large, these patients who fly from all over the country to the NCI for studies like this, to look at, enrolling in one of the NCI Connect studies or something else in the Neuro-Oncology branch, who get referred to us for a biopsy, they're typically all in on the research part. Certainly, they're hoping that there's something we can find that will benefit them, but they generally are very enthusiastic about the idea that this biopsy could one day lead to some advances in the field. So it's not something where you're pulling teeth trying to convince patients to sign up for these things. Yeah. And when it comes to the data sharing aspect of that, that's the other part they're demanding. If they're going to take on this risk and participate in something like this, they want to make sure that it's not something that's just benefiting your career or your institution. They want to make sure that their data that they're making available is widely available. So I think, continuing to push those efforts in consortia that share this data widely, I think is paramount.
Yeah.
My hat's off. You've done a great job. I was impressed that the practice variations, especially given how rare the tumor type is, how it can really impede the ability to make a progress in a rare tumor histology like this. But one of the things that I think is a very tangible and attainable goal is just we as the neurosurgical community need to have more practical courses and discussions and didactic sessions that really raise the level of awareness about the overall safety and efficacy, relative low morbidity for biopsies, raise a bit the awareness of some of these clinical trials. And then also I think that there was a subset of individuals who noted just H&E testing. And I think we all can acknowledge that that's probably a thing of the past, and that mutations and genetic studies are really, if you don't have those at your facility, there are options to send out to other academic centers, or even corporate entities that can provide some of the mutational studies, because we know, and we've had other papers and other webinars that are coming out that are really going to be stratifying the gliomas as a whole, that are going to be much more on the basis of molecular rather than histopathological features of these tumors. So, but great study, and I think some very attainable goals to hopefully, which this webinar did, which is to hopefully raise awareness of this tumor type, the need for tissue, and the options that are available, and a relative safety and efficacy, which I think you both have made a strong case for to obtain tissue. Thank you.
Absolutely.
Thank you for having us.
Yeah, guys, thanks so much. So this will be, posted on the YouTube. You guys can feel free to share everything. It'll be the JNO YouTube on the Lenox Hill YouTube. And then right now it's on the IG Live. Again, the JNO Instagram Live will go live probably next week, hopefully. All right.
Yep. Next week.
Fantastic time. Thanks so much. We keep them short and sweet so people don't lose interest. But
Sounds good. Thanks for having us.
Thank you.
Thank you, guys. Take care. Have a great night.
Bye-bye.